My name is Sean Fitzgerald, and I'm speaking to you today from Jasper. I would like to begin today's webinar by acknowledging that the College of Physiotherapists of Alberta's offices are located on Treaty 6 territory, as well as the Métis Nation of Alberta's Region 4, which has been and continues to be the home of many Indigenous peoples since time immemorial. The College of Physiotherapists of Alberta recognizes that Indigenous peoples have been helping many live healthy lives on this land long before settlers arrived. With that, we commit ourselves to helping move people forward in their journey towards a good life, and doing so in a way that follows the spirit and intent of treaty, that of peace, friendship, and understanding. We also recognize that people from across Alberta and beyond are joining us today, and encourage you to take a few moments to learn more about the lands, peoples, and treaties with which you may be in relationship. It is my pleasure to welcome Beth Gorczynski. Beth is the lead on the Health System Improvement Team at the Health Quality Council of Alberta. She has over 25 years of experience in the health sector, working within Alberta Health Services, as well as in continuing care, supporting quality and safety in the delivery of health services. Again, I'd like to welcome Beth, and I'll hand this presentation over to you. Take it away.
Thank you, Sean, for that introduction. I'm very pleased to be here today to talk about disclosure and responding when things don't go as planned. In my presentation today, I will be highlighting why disclosure is important, how it supports patient safety, what it involves, and the challenges of doing disclosure well. And as Sean mentioned, there will be time at the end of the presentation for some questions. I want to acknowledge that we are on the traditional territories of the First Nations, Métis, and Inuit peoples who have lived on and cared for these lands for generations. We honor and respect their history, languages, ceremonies, and cultures. We are grateful to work, live, and learn on these traditional treaty territories and Métis lands in Alberta. I wanted to start the presentation this morning by sharing a couple of comments from a video that was produced by the Canadian Patient Safety Institute, which is now part of Healthcare Excellence Canada. I think these statements reflect what disclosure is about: helping patients, families, healthcare providers, and organizations heal and to find meaning in a terrible situation, and also to make healthcare safer. Tanya Barnett is a mother whose teenage daughter died because of breakdowns in the healthcare system. As a result of that experience, she became a strong advocate for disclosure and advocates for a restorative approach to handling medical harm for both patients and the providers involved. Tanya's story is one of many Healthcare Excellence Canada videos of patients, families, and healthcare providers sharing their stories about harm in healthcare. These stories are powerful reminders of the human impact of these incidents and why disclosure matters. Unfortunately, we know that preventable harm happens in the healthcare system far more often than anyone would like. A recent report from the Canadian Institute of Health Information indicates that out of every 17 hospital visits, a patient experiences harm that is potentially preventable. While we cannot always control what happened, we can control how we respond to those events. Patients understand that things might happen, but they will never forgive us if we are evasive, defensive, and fail to offer the support that they need. An ineffective response following an incident that resulted in harm can leave people feeling fearful or anxious. They lose trust in the system. The individual may feel dismissed and feel like they don't matter. A lack of information can lead them to pursue other options, such as a complaints process or legal action, to understand what happened and why it happened, in order to make sense of the incident and to help them move past anger and distress. A consistent and transparent approach, on the other hand, helps to restore trust, promote healing, and improve safety. So what is disclosure? Disclosure is an open discussion about an incident that resulted in harm. It involves the patient, their support system, and the healthcare team. And most importantly, it is a process, not necessarily a single conversation. We know that patients may experience harm as a result of the progression of an underlying disease, as well as from known risks of an intervention or a treatment. When we talk about disclosure, we are specifically referring to the conversations that happen when a patient is harmed in the delivery of health care as a result of a system failure or provider performance. So why is disclosure important? There are many benefits to disclosure, but most importantly, disclosure is the right thing to do. Patients have the right to be informed, and healthcare providers have a legal and ethical duty to disclose when harm has occurred. Additionally, disclosure helps to restore trust within the patient-healthcare provider relationship. It ensures that informed choices can be made and decisions be made around the patient's ongoing plan of care and their treatment. Disclosure gives us an opportunity to identify the support required by the patient and their family to address the impact to them resulting from the harm experienced. Disclosure can provide healthcare providers and the organization an opportunity to heal. And disclosure promotes a culture of safety, where learning from adverse events is viewed as an opportunity to make the system safer. I do want to highlight that disclosure is a practice that lives within a broader culture of safety. Safety culture reflects an organizational understanding that the delivery of safe care requires a commitment to continuous improvement and engages everyone in the safety processes. Just culture is a critical component of a safety culture that is primarily concerned with how an organization responds when something goes wrong or nearly goes wrong with patient care. In a just culture, healthcare workers are treated with respect and feel supported when something goes wrong with patient care. There is no room for shame and blame in the event of an error. The actions of people involved in an adverse event are assessed fairly, and that assessment takes into consideration the context of the situation and the contributing system factors. Organizations in a just culture ensure that patients are treated with respect, dignity, trust, and openness when something goes wrong with their care. Disclosure within a just culture improves patient safety by promoting open discussions about safety issues, by providing opportunities to learn from the unique perspectives of patients and engaging them in the safety of the organization. And it focuses everyone on learning and improving systems, as I said, not shaming and blaming those involved. And that is a fundamental attribute of a safety culture. There's not time today to talk in more detail about a just culture, but I have provided a link on this slide to the HQCA Just Culture website if you would like to get more information. I want to talk more specifically now about the disclosure process. Whether you work in a large organization or in a small clinician operation, disclosure should always be done in a systematic way and follows the same process. Using a consistent approach helps to ensure that all of the required information is provided and that the information shared is factual and agreed upon by everyone involved. Ideally, everyone involved in the care of the patient is aware of what is being communicated, and they are involved in determining the facts of the event. If there isn't a team involved, having a colleague who can support you with the conversation and the review of the incident can provide valuable support and insight into the process. Disclosure conversations can be challenging and emotional. It's important to take time to prepare and ask for support or advice if you are unsure of what to say. Before talking with the patient, you will need to confirm the facts of what is known and understand what, if any, further action is required. You don't need to have all of the information to start the process. The most important thing is being sure that the information you share has been verified as factual. For example, you shouldn't disclose that a piece of equipment malfunctioned based solely on the incident report or a statement from a staff member. The equipment needs to be checked to confirm that it truly did malfunction and that user error or other issues were not involved. It might be tempting to try and script the entire conversation in preparation, but it is important to balance being prepared with engaging in a genuine conversation that allows the patient to share their perspective. This presentation will be primarily focused on formal discussion related to a serious adverse event. However, it should be noted that many safety incidents result in little or no harm. In those cases, disclosure may take place between the patient and the healthcare provider in the care setting, rather than a formal meeting with multiple participants. Regardless of the setting and the number of people involved, the same process should be followed, and the conversation should be documented in the patient's healthcare record. In some cases, the initial disclosure conversation may be sufficient to meet the patient's information, emotional, and clinical needs, but it is common for additional meetings to be required as more information about the event becomes available through investigation. I will talk in more detail about the disclosure process for both the initial and ongoing meetings in a few minutes. So when is disclosure required? Although disclosure policies and processes may look different in different settings, there is consensus on the fundamental concepts. It is generally accepted that disclosure should occur when the patient experiences harm, if there are changes to the care or monitoring required as a result of an incident, or if there is a risk of future harm. Healthcare providers identify some conflict regarding disclosure for minimal or no harm events, as the potential impact is not always immediately clear, or they may feel that informing the patient would cause unnecessary distress. In most cases, it is suggested to err on the side of openness and transparency, considering what the patient would want to know or would benefit from knowing. It's also important to recognize that harm involves more than physical harm, and we need to consider the emotional and psychological impact of the event on the patient, as well as the impact to the patient's daily life and their ability to maintain the tasks at home that are important to them. Also understand that patients have a different perspective about what they consider harm than healthcare providers have, and what we consider to be minor impact may feel more significant to the patient. Disclosure should happen as soon as possible after you become aware that an incident occurred involving harm. Again, you don't need to have all the answers, but if you wait until after the investigation to talk to the patient, you lose their trust. They may feel that you are ignoring the incident or that you are trying to protect yourself. So who is part of disclosure? The individuals involved in the disclosure process really depends on a number of factors, including the harm experienced, the information being shared, your organization's policy, the care environment, and the needs of the patient. As much as possible, the decision of who to involve should be driven by the patient, understanding who they have a relationship with and who knows their care best. Try to balance the number of participants in the meeting to ensure that the patient and their family do not feel intimidated or overwhelmed by the number of healthcare providers, and that there is not a power imbalance. Patients often want to hear from the healthcare provider who is involved in the incident, and including that individual can actually support healing for both parties. There is a growing awareness of the value of bringing the involved provider and patient together, although it is not always common practice. What patients want from disclosure is well established, and this forms the basis of disclosure conversations. Patients want an acknowledgement that something has happened. They want to know what happened and why it happened. They want to understand what is being done or what will be done to prevent others from being harmed, and they want an apology. And in addition to those things, they want to be heard. People want the ability and the opportunity to share their experience of the event and to tell us how it has impacted them. It can be hard to know exactly what information to share in a disclosure conversation, and the specific information shared will be based on the circumstances of the incident, the nature of the harm experienced, the healthcare providers involved, the care setting, as well as the patient themselves. Regardless of those things, the information shared should provide patients with a complete understanding of the event and the harm that occurred, as well as steps taken to improve safety. All information should be factual and relevant to the incident. It's important not to share opinions, speculation, or blame, information about other patients, or administrative actions that are taken with involved providers. You can share the name of the providers involved if relevant to the discussion, just not any disciplinary actions. It can be helpful to be clear up front with patients what will and won't be shared to avoid frustration. For example, a common question from patients is about disciplinary actions for the involved healthcare provider. So it is important that they have a clear understanding that that information will not be disclosed. Another common example is information gathered in investigations that involves the opinions from staff about why something did or didn't happen. While this is important in the context of an investigation, it should not be considered a fact and would not be shared in disclosure. This can be particularly challenging in small organizations where the individual leading a disclosure conversation may also be leading the investigation of the incident and the assessment of the healthcare provider involved in the incident. Facts related to the patient's care and incident will most often be documented in the patient's chart, and that is typically a good starting point for your disclosure conversations. Patients should also receive clear information about the consequences of the incident as it relates to their ongoing care and treatment in order for them to make informed choices about the plan of care. The other next steps that should be disclosed, if they are relevant to the situation, would include information about the investigation that will occur and any further meetings and communication of actions taken to prevent future harm. A typical initial disclosure meeting will involve the steps listed on this slide. Please note that they do not need to be completed in this order, but all of these things should be addressed in this disclosure conversation. Limited information may be available in the initial disclosure to provide an explanation. It's okay to say, we don't know how this happened, but we are going to find out. Even if what appears to be an obvious error has occurred, seldom are all the contributing factors known initially, and it is important not to prejudge or make assumptions. Following a structured approach and confirming facts before the meeting can help you avoid sharing information that has not yet been established as fact. As part of the explanation, be sure to discuss the known impact to the patient and their ongoing care. The apology offered should be in keeping with what is known. In the initial disclosure, this is typically a statement of regret or sympathy that harm has occurred. In most cases, analysis to determine if system failure or provider performance was an issue will still need to be conducted. Therefore, a statement of responsibility is likely not appropriate at this point in time. Disclosure is not a one-way conversation. Make sure to listen to the patient and give the individual and their family a chance to tell their story, what they observed, experienced, and how the event has impacted them. You may be surprised to hear that they have a very different perspective of the event than you as a healthcare provider have. Hearing their story also helps you to identify what support may be required. Validate that with them and ask them what they need. It's helpful to know what support you can offer before you meet so that you don't commit to something that you can't actually deliver. For example, what, if any, financial remediation are you able to offer? Is a referral to another healthcare provider in the care setting an option? Do you have access to emotional or psychological supports that can be offered? What you can offer is generally determined by your organization policies and should be directed by the patient and family needs. Commit to gathering information and having further discussion. Make sure that the patient and their family understand how you will be investigating the incident, what the timelines are, what you will share and won't share, what they can and when they can expect to hear from you again. It's helpful to provide a contact name if they have any questions or concerns. People often need time to process information that has been shared in a disclosure conversation, and questions afterwards are very common. If we don't provide answers to their questions to the best of our ability, they are going to fill in the blanks with their own assumptions. Document the conversation on the patient's healthcare record, identifying who participated, the facts that were shared, questions asked and answered, and the next steps. Sharing a copy of the discussion with the patient and family further supports transparency and helps to build trust. Although the focus of this presentation is on disclosure, incident investigation and disclosure are closely connected in that both processes seek to understand what happened, why it happened, and how we can prevent it from happening again. I don't have time today to talk in detail about incident investigation, but wanted to point out that the HQCA has information on their website about two different methodologies that can be used to review patient safety events. One from a system perspective, and a second one that fairly assesses individual actions in these events. The use of the systematic systems analysis methodology for incident review will help you to establish facts and consider all aspects of the healthcare delivery system, as well as identifying opportunities for improvement in the system to improve patient safety. This information in turn can be shared in disclosure addressing the patient need for an explanation and their desire to see actions taken to prevent future harm. This helps them find meaning in their experience. Patients are invested in the care provided, and they have unique insight into how that care is delivered. They see things in care delivery in the environment that we as healthcare providers miss as we become so accustomed to how things look and the way things are done. Disclosure conversations provide patients with an opportunity to share that perspective and identify where they see opportunities to improve the system. This can be particularly valuable in small operations where it's challenging to conduct a thorough investigation when you have limited resources. The goal of incident investigation is to identify opportunities to make system changes to improve safety. And as I've noted, this is very important to people who have been harmed in a patient safety event. In order for those identified actions to be meaningful, however, they must be specific and relevant to the incident. Broad statements about change such as, we're going to review our communication processes, or we're going to change how we do our intake, can leave people feeling like you aren't taking it seriously and that nothing meaningful will happen. The actions should also address the questions or concerns identified by the patient. You might have some great recommendations to improve safety, but if they don't get at the safety issues that were important to the patient, you could be missing opportunities for improvement, and you can also leave them feeling like their concerns were not even considered. For example, if your actions are all focused on the equipment involved in an incident, but the patient was most concerned that a healthcare provider didn't have access to important clinical information about them, they are unlikely to feel that the incident has been effectively resolved, and you may be missing an opportunity, an important safety issue. Finally, patients may also want to be actively engaged in the process and may even become your best champion in implementing change. Being involved in supporting change, again, can be a way for the patient to heal from the experience. Depending on the nature of the event and the complexity of the review process, multiple meetings may be required to keep the patient informed about the investigation and to address ongoing questions and concerns. Ongoing disclosure conversations follow a similar process to the initial disclosure, and they are intended to share additional facts as they become known, clarify information, and allow the opportunity to respond to additional questions. An acknowledgement, apology, and offer of support should always be included. An apology at this point may include a statement of responsibility, if appropriate, based on the analysis of the event. The disclosure process should be considered complete when the patient feels that they have an accurate understanding of the adverse event and the actions taken to prevent a reoccurrence. When they feel that they have the information necessary to make informed decisions about their care, and answers to their questions to the extent that you have been able to provide them. If the patient feels that resolution cannot be achieved through the disclosure process, they may want to address their concerns through other processes, such as initiating a complaint through the Office of the Alberta Health Advocates or their relevant regulatory college, and they should be supported to do so. Again, all disclosure conversations should be documented on the healthcare record and a copy of the information provided to the patient. I do want to speak briefly to the concept of an apology as part of disclosure, as I know that the idea of offering an apology may feel uncomfortable. Historically, when I started in healthcare, advice was to never apologize or even acknowledge that something unanticipated had happened. That did shift over time to where healthcare providers were supported to express remorse that something had happened, but that still did not extend to a more explicit apology. The recognition of the importance of apology and the introduction of apology legislation in many jurisdictions, including Alberta, has further shifted the conversation, where a full apology is now supported and may even include a statement of responsibility where appropriate based on the analysis of the event. This shift is reflected in AHS policy, where they define apology as a genuine expression of sympathy or regret, a statement that one is sorry for what had happened. In the definition, they further state, an apology includes an acknowledgement of a responsibility, if such responsibility has been determined after analysis of an adverse event. That definition is consistent with the definition offered by the Canadian Medical Protective Association, as well as information in the Canadian Disclosure Guidelines. Although there is agreement on what an apology includes, it does not mean that a full apology routinely occurs or that healthcare providers are comfortable with the concept, leaving a gap between what patients want and what is typically offered in disclosure. I also want to briefly highlight some common challenges. Disclosure conversations can be very difficult for both the healthcare provider as well as the patient and their family. Knowing some of the challenges that you might face helps you be prepared and better manage those issues as they arise. Strong emotions, including anger, sadness, fear, and even disgust are not uncommon, particularly if significant harm was experienced. Dealing with your own emotions first helps you to remain calm and control in the meeting. Anticipating the patient reactions and planning how to respond to different possibilities will also help give you a sense of control. Active listening and validation are important tools. Don't feel like you always need to jump in with an answer. Listening and restating what you heard demonstrates genuine interest, and it helps to focus in on what is most important to the patient. Try not to take things personally. This can be really difficult, particularly if the patient's anger is directed at you or one of your team members. Remembering that they are responding to a stressful situation the only way that they know how. And it's also okay to stop the discussion if emotions are getting in the way of a productive discussion. You should never be in a situation where you feel unsafe or you are feeling like you're not going to be able to respond appropriately. Take a break and plan to meet again once people have had a chance to calm down. Managing information needs can also be challenging. Patients often ask questions that we may not be prepared to answer, or we may not have the information we need to respond at the time. Gathering the facts in an organized way helps to ensure that you are not missing things that the patient is likely to want to know. Admit when you don't know. It's better to be honest than to talk around a question and appear to be evasive or that you're hiding things. Talk to others. Sometimes you may need to consult with people outside of your organization, like your insurer or regulatory body, to confirm what information can be shared, or to understand what other factors may be relevant to the incident. Anticipating what information the patient needs can help you be prepared. It's okay to ask them what they want to know in the early stages as well, so that you can be sure to address their questions. Again, being clear about what information won't be shared can also help you manage their expectations. Depending on the incident, it can also be difficult to keep the conversation on track. This does get easier with practice, and having education about disclosure and opportunities to role-play disclosure conversations is helpful. Go in with a plan, but don't be surprised if things don't go according to that plan. Having the plan will help you, though, redirect the conversation to get back on track. I have found that it is helpful to ask permission to shift the conversation. It makes it easier to change the topic, and it prevents people from feeling like they are being cut off or ignored. For example, if the patient is starting to talk about negative experiences in the healthcare system that are not relevant to the incident, you can say that you appreciate that those things are important, but that you really want to focus on the misdiagnosis or the medication error or whatever the incident is that occurred for right now. Here are a few additional tips that I wanted to share that really reflect good communication strategies in building positive patient-provider relationships, but are especially important to consider in disclosure conversations. The use of simple, jargon-free language helps to ensure that patients will have a clear understanding of the event as it happened and the impact to their health care. Holding conversations in a quiet and private location and minimizing interruptions helps to manage emotions and provides the opportunity to demonstrate respect and compassion to the patient. Pay attention to their body language. It helps you anticipate how they may be reacting and what they're feeling. Slow down and accept moments of silence. Again, it can be difficult, and we may always feel like we need to jump in with the information, but it's okay just to pause and hear what's being said. Confirm that the individual has understood. They may feel intimidated or unsure of asking questions, so it is helpful to have them restate some important information back to you to demonstrate their understanding. And consider cultural and language differences and how they may be interpreting things that you are sharing. Before I open this up for questions, I also wanted to comment on some of the challenges in implementing disclosure. Even though disclosure is known and accepted and established concept, a gap exists between policy and practice. The gap is attributed in part to common barriers to disclosure that are identified in the literature. And these barriers include a fear about the consequences of disclosure. Healthcare providers worry about losing respect from their patients or their colleagues when an incident has occurred. They also are fearful of identifying an error as it may result in discipline, losing their license, or even being sued. Additionally, there is a lack of skill in disclosure conversations. Disclosure skills are not necessarily taught in school. There may be limited education about how to facilitate a disclosure conversation. And disclosure is not something that necessarily needs to be done frequently. So it is really hard to build skills or to gain experience in conducting these types of conversations. There's also a lack of clarity regarding the minimal or no harm events and the different perspectives of harm between patients and healthcare providers. This leads to an uncertainty of the benefit of disclosure and questions about whether or not disclosure should occur and in what form it should occur. The absence of a just culture is one of the most important barriers. This is tied closely to the fear of the consequences of disclosure that I had mentioned previously, but it also is related to staff and patient comfort with identifying and bringing forward incidents. If we're not aware of incidents, then we are not going to be prepared to disclose those incidents to the patient. And in fact, a high number of disclosures occur as a result of patients coming forward with questions or concerns or having to initiate a complaint, rather than healthcare providers initiating a disclosure and result to an incident that has been identified. The HQCA is currently in the process of reviewing and refreshing our disclosure resources to help bridge the gap between policy and practice and address some of the barriers that were identified. I have popped a couple questions in the chat as I'm interested in getting your feedback about the barriers to effective disclosure in Alberta and what resources or strategies are needed to address those. If you're able to take a minute to reflect on those questions and pop some answers into the group chat, that would be great. And you're also welcome to reach out to me after this presentation with your thoughts. There are many resources out there already related to disclosure, and so we really want to ensure that healthcare providers have access to the information that they need, not just to understand disclosure as a concept, but the ability to practice disclosure and to build on those disclosure skills in practice. Thank you for your attention, and I'm happy to open it up for questions now.
Well, thank you very much, Beth. That was great. So we do have a couple questions in the queue. So we'll start with a couple, and then we'll see how far we get. Okay, so the first question was regarding disclosure of near misses. So companies keep track of near misses. Patients might have actually experienced, but they would perceive a near miss. Something occurred. Guessing nobody got really injured, but the patient kind of maybe noticed that there was an error, an issue in something that occurred in clinic. Do you go through the same disclosure steps? I think kind of, the same process in which you kind of discussed in which there was actual patient harm?
Yes. The short answer is yes. There's differing opinions about disclosure related to near misses. Patients in general state that they would want to know, and as you mentioned, often they actually are aware that something almost happened. And certainly in that case, if the patient is identifying a near miss, disclosure absolutely would occur and would follow the same process. Some people believe that disclosing near misses may actually erode trust in the system if patients were not aware and harm had not occurred. So it really is an organization decision. Disclosure is considered discretional in the event of a near miss, but anytime disclosure happens, regardless of whether harm was experienced or not, the same process would be followed. It would be about acknowledging what happened, explaining what happened and why it happened, and the steps that are going to be taken to prevent it from happening again, as well as expressing that apology that something had gone wrong or almost went wrong.
And I guess a follow-up to that question would be, would that, and I guess kind of maybe, I'm not sure if you're the right person to answer this or not, you talked about documentation of disclosure, and that lives in the patient's medical records. So if you were potentially to kind of disclose a near miss, would you also kind of include that in the medical record? I'm not sure, like I said, if you can answer that or not, but just something that kind of popped into my head.
It would be what would be in the medical record would be the conversation or the discussion that was had with the patient, not necessarily. The information about the incident lives in a separate incident reporting system, and similar with any of the investigative processes that happen, live in a separate documentation system. In the patient record is really any documentation regarding the conversation that occurred with that patient, which would include the facts of the incident that were relevant to that conversation.
That makes so much sense. Okay, so the next question we have is, we do have obviously a lot of frontline workers and people who aren't necessarily in charge of or responsible as a lead to kind of create a just culture in the workplace, or a lead. Is there steps or things that you can kind of readily identify that maybe you can draw from the resource that you mentioned that would kind of help clinicians kind of implement a just culture in their workplace?
Mm-hmm. Certainly on the HQCA Just Culture website actually does include information for providers, for managers, for organizations, and the different actions that can happen at each of the levels of the organization. think one of the most important things for healthcare providers at an individual level is to really reflect and think about our own perspectives of errors, mistakes that happen, and how we treat our colleagues when things go wrong. Are you supportive, or do you judge based on something that has happened? Do you think of them as less effective in their role if a mistake has happened? So I think as individuals, how we respond to our colleagues, if we're supportive and if we understand that we all make mistakes. Every single one of us will make mistakes in our personal life and our professional life. That is a part of being human. And so how we as individuals respond to each other in those situations is a really, really important part of just culture and something that is completely within our own control. The other part as an individual, I think, is important to be involved in investigations and to be able to look at incidents that occur to understand not just who did what, but to understand why something happened, and to really look at those system factors that underlie, was the form the right form? Was the equipment working? What are those processes? Did the staff member have access to the information that they needed to be doing that particular job? And really having, being an active part of that and an active part of trying to understand. Those are definitely things as individuals we can all do to support a just culture in our organization.
All right, thank you very much. So we've got a couple more questions here. So and you kind of had actually kind of led into it with your last, answer, is again, like frontline workers, like even I think those in management or those that own clinics. I mean, how many of those really feel, I think, comfortable conducting an investigation? So what are, like, again, like referencing back to some of the resource material that you may have included in the presentation, what are the main steps that we should keep in mind if you are conducting an investigation using, I think it's your SSA or JSA resources that you link to with the QR codes?
Mm-hmm. So I think the first step is really gathering information, and both processes go through the creation of a timeline to understand the sequence of events that led up to the incident, and that's certainly regardless of experiences in conducting events or investigations. It really is important to be able to outline the different things that happen in that sequence of events that led up to the incident. The systematic systems analysis process asks you to look at information in 5 different areas, which make up all of the components of the healthcare system. And that involves the patient, the team that was involved, any equipment or supplies, organization, which would be things like policies and education and processes that are established. And then it also considers the regulatory environment and, sort of the broader outside influences that would potentially have an impact. And so really gathering all of that information and putting that information into a timeline to understand what happened. And then an analysis step that looks at how that information fits together to understand sort of what was in place prior to the event, the structures that are there that are factors, the processes of what happened, and then what were the outcomes for the individual, for that team, and for any of the other areas that you've looked at. So it's a very systematic way of looking at things, and it's systemic in the sense that it looks at multiple areas. And then that analysis to find the patterns through that. So on the HQCA website, we do have a guidebook. It is just in the final stages of being updated that walks through that investigation process. And there will be an online module to accompany it that walks through it, as well as a workshop that people can attend to go through a case study to put that methodology into practice. And the just individual assessment process is the process that focuses on evaluating individuals' actions within an incident and considers those system factors that have been identified. It considers how those things impacted what that individual did or didn't do in the situation. And we also have an online module that walks through that process and opportunities to attend a workshop to apply a case study to using that process. One of the things I will say about the just individual assessment process that I think is really, it challenges some of our common attitudes and our responses to incidents, and it really considers the role of human error and acknowledges that people people can't control when they make a mistake, and so discipline is not warranted for if it is truly human error that was identified. And so it really challenges some of our traditional responses to incidents, and it really is, again, a very foundational aspect of just culture, and it links so closely with disclosure because it allows us, when we have these processes in place, it allows us to feel comfortable having much more open conversations with families because we can very clearly describe our processes, and we know that those processes are consistent and fair and focused on system improvement.
So, and yeah, great answer. Actually, it kind of cleared up a lot of stuff. So I think kind of we just had one last question in the queue, which I think we've kind of hovered around with as you answered some of the other questions. So I think too, like when you're in a environment, whether it's, you know, private, public, environment, kind of workplace, if you like until one of these incidences happen, I think kind of sometimes we're not really sure whether or not we work in an environment where there is like a just culture. So one of the questions that was like, you know, you had put in the second last slide, like the absence of a just culture. Is there any like yellow flags that would help you identify whether or not you're, you know, the people around you or the people in leadership roles are actually really kind of tuned into this until, I mean, like I said, sometimes you don't know until something happens and you see there's a lack of something in place in order to address this appropriately. Is there any like yellow flags or things that, you know, proactively you could implement to create a just culture? I don't know if that's kind of going back to the question we already asked before, but I think kind of maybe identifying absence of, or maybe you can clarify that.
I think absence of a just culture is probably the biggest indication of the absence of a just culture is that people don't bring forward safety concerns. So incidents don't get reported. People don't feel comfortable saying that something's wrong. So if, you know, good example, staff member observes a team member doing something that they know is unsafe. You know, my background's continuing care, so they see somebody using a lift without a second person there, or they walk in and their staff, their team member hasn't waited. They don't feel comfortable talking to their team member about it. They don't feel comfortable talking to their supervisor about it. So if you're in an organization where you're not seeing incidents being reported, or you're not hearing about safety issues, that's probably a good indication that a just culture is not there, or that it is really sort of a low-level safety culture. That's probably the biggest indicator. The other, I think, is just do you know what would happen if there was an incident? Do you know if you made a mistake, what would happen? If you can't answer that question, that's another indication that there may not be a just culture, because in a just culture, everybody has a clear understanding. I know if I make a mistake, I know exactly how my supervisor will respond. I know how to expect my colleagues to respond, and I know the process that will happen. So I think just culture is about having established processes, and it's about people knowing the processes, and it's about people actually living by those processes as well.
Thank you very much, Beth. So that comes, just going to double check and make sure we didn't have any other questions that kind of popped in towards the end. Okay, so Beth, thank you very much for your time today and the work and effort that you put in to create the webinar for us today. We're all very grateful and thankful for the time that you spent with us today and taking the time to answer all of our questions. That will be the end of this webcast. So once again, a big thank you to Beth. Just as a heads up, our next webinar will be November 3rd at 8 a.m. and that is Critical Research with Tim Barlott. You can access that information on our website. And if you have anything else you will need, please feel free to reach out to Beth or myself regarding any of the content on this webinar. Thank you very much and have a lovely rest of your day.